Focus is really going to be how do we feed that pipeline. I think Janet pointed out that there's a real crisis at the present time in terms of the development of new therapeutics, but there's also an opportunity, and a particularly strong opportunity now I think scientifically comes forward because of what we're learning about the causes of rare disease, and also what we're learning about the pipeline for developing therapeutics and ways to engage the academic community in a fashion that hasn't really been the case before, in which I think the academic community is hungry to begin to be a broader participant in this, but needs some tools, some support. And clearly there's also an opportunity here for partnering with foundations, with patient advocacy groups, especially for rare diseases where it may not be so easy to line up thousands of patients for a clinical trial. How do we make sure that we're paying attention to that part? So what I want to talk about is a potential novel partnership here model between public and private, and by that I mean the government-supported academic research through NIH, as well as private foundations that are interested in specific diseases, as well as FDA oversight, and as well as bio and pharma, who are going to play a critical role here. My bottom line is going to be perhaps we can come up with a model which de-risks these kinds of projects in a way that makes them more attractive for commercial development, not in any way superseding what the private sector does so well, which is to get drugs into patients effectively, but actually makes a project which may otherwise seem commercially not viable because of the limited market size begun to be more appealing. And I think what we're talking about then is a systemic solution, not a series of one-offs, identifying the way to put a process in place that provides the tools that all the partners need. For NIH, that means providing tools to investigators who really are interested in getting into more translational applications of some area that they happen to be the world's expert, but don't quite know how, have never really learned about how you make an assay work in a high throughput setting. For the private sector, I think that means coming up with a paradigm that really does de-risk projects, protects the IP in a way that it makes it still attractive for licensing, but provides them with an opportunity to go after a rare disease without having to assume a huge financial risk right up front. For the patient groups, I think it means providing them with tools that enable this ability to do natural history studies and begin to identify clinical endpoints without having to figure out how to do that from scratch if you don't happen to be a large organization with a lot of resources. I think those systematic solutions are potentially achievable, but it doesn't happen by chance. I think it really is the kind of conversation we're having right now to try to bring all of those stakeholders together and to see how each one of these pieces is essential or the whole thing doesn't work.
I left BioMarin and I set up a foundation. We're setting these Cure the Process campaigns to try to fix these areas, and I think we want to work with all of you, with FDA and everyone, to figure out how to make improvements in the process that will allow us to move forward. And I want to point out to you that while there's a lot of success and we could be complacent, you know, I look back at the story in the Titanic when people were sitting in their boats and they were singing so they didn't have to hear the people that were drowning. Well, there are patients out there with genetic diseases who are the same as drowning in the cold, dark Atlantic. And we could say, well, we want everything to be the same, but I think what we need is smart. We need the regulation to be smart and pick and do the right thing for those patients and not worry about the risk to us in our situation, status quo. We need to go back and start figuring out ways to catch some more of these patients and take a certain amount of risk, that's smart risk, and to move it forward. So I'll be spending the year working on this, assembling a scientific committee and focusing on creating the right kind of scientifically sound changes and proposing those for improving the process and getting more rare diseases treated. Thank you.
NORD should develop the vision for the new paradigm of drug development, okay? And I agree with Francis, this may be the new paradigm of drug development writ large, but we could start with orphans, okay? We've had a reasonably successful drug development paradigm for orphan drugs, because we've gotten some orphan drug treatments. So that's really good, because otherwise there was despair before that. But now with the new science, there's an opportunity to go much further and develop many more. And so articulating that vision to everyone, to patient groups, to the Hill, to everyone, I think it goes a long way, because I'm not sure, and when we started this morning, that people share this common vision of this tremendous opportunity. It's now opening up for a new kind of drug development. And I think that would be, in and of itself, that's not a specific action, but it would go a long way to say, where should we go in the future? I would suggest to NORD that one of the things you ought to put together as a part of this is a research agenda, okay, that looks across rare diseases. And people have referred to this already. Look at, what about the existing drugs? What could any of them apply to rare diseases? What pathways, what are the diseases, so that you're putting forth, you're not saying we need this disease needs a treatment, this disease needs a treatment, but here's the research agenda in this area, and this will benefit our understanding of biology and pathogenesis, not just these specific diseases.
What I heard this morning is, look, FDA wants to be flexible. It needs real partners. It doesn't have all the answers up front. It needs collaborators who are going to push the FDA to work to get answers together. The flexibility is key, and those areas include assay, preclinical, clinical validation. They are all roadmap issues, and there need to be entities that are taking responsibility for driving this. But talk about what you're hearing. I mean, are you saying the same thing? Are there differences? Put it together for us.
I think what we heard today, starting from Governor Thompson, was, there's some opportunities on the legislative incentive front. That's number one. So you need to think those through. I think what I said and what Francis said is matching. He was, he talked more about the NIH and the biomedical research community can get more involved in discovery and early development, especially with some assistance, with additional funding and so forth. But that the opportunities are there now, which is also what I said, that the scientific tools are available for people other than simply large drug companies to be involved in these activities, although the partnership, I think, needs to be long. So what I heard Francis saying, and others also, is that the later barriers to preclinical and clinical development also need to be addressed, and I agree with that. Some of that is regulatory, and some of that could be strictly done in the public-private partnership by NORD or others in putting together the natural history, the disease models, the research networks, the availability of patients, in other words, the tools, so that when these discoveries come forward, they can be rapidly and effectively evaluated. And then what I heard is, from the FDA standpoint, people can push us, they can submit draft guidance to us, they can work with us, that perhaps we need to take a more realistic view of diseases that have 10 patients or fewer, or 100 patients or fewer, as far as what could realistically be fit in within our current statutory requirements, that drugs be safe and effective, or devices be what have you. So what I heard is a whole incremental series all along the development and access pipeline of interventions that could be done that could make a major difference in development over the next 5 years. That's what I heard.